basically, the failing single ventricle. If we speak about it, I thought we should take a look for this picture because William Harvey said that the veins allowed blood to flow to the heart and the valves maintain the one-way flow. Unfortunately, for all who come later, especially in the 20th century, they forgot that they talked about the normal physiology, not about this kind of the flow. And also, if we are happy that this patient is probably doing well, we know nowadays that we got many problems after we thought that this decision or this idea can be used in the univentricular heart. And also, the man who make this mistake, the first one, told us 20 years later that it is not perfect. This is only palliation, and the mortality 16 years after the introduction of the Fontan operation was about 60%, and the neurological events, cardiac failure, and so on, rise with the time go on. Therefore, we need strict factors to select our patients, and at first they were 10 in this corner, and after that, this publication from Birmingham, and if we take it on the Berlin way, then it is only 2, the ventricular function and the pulmonary vascular resistance. But I summarized the data that were presented and published from 1990 to 2013 regarding the late mortality and 10 years survival. And in the publications, we have the data that arise from 63% in the 90, from 68 to 90, up to 85 to 95% in the last decade. Therefore, we're doing it much more better at the beginning. But according to these results, in our institution, we have nowadays about 200 patients. It's not a huge amount, but it is a consequent work with these patients. We have acceptable mortality, early and late mortality, and we are still satisfied that 20 years later, we have about 90% of the patients who are still alive. But with this, we got many problems. And the topic of the presentation is the failed single ventricle. But between all these complications that we know after the Fontan operation, the last one, I do not really know how we can treat it. We can make anything against the protein-losing enteropathy, we can treat arrhythmias, we can prevent thrombotic complications, and so on. But what we can do for the single ventricle, this is a question. We know that the pulmonary arteries, without stress and without flow volume, show us no normal growth. And according to the growth of the patient and not growth of the pulmonary arteries, the pulmonary resistance increased over the time, and this is the limitation of the Fontan circulation on the long term. We know also that the ventricular function looking so good in this one, young adults, and not more so good in this one, also young adult. And we measured the flow on the MRI, the flow volume, that we have normal cardiac index in the first one, and only 2.4 liter per minute per square meter in the second one, according symptoms with chronic ascites, protein-losing enteropathy. And if you take a look on our total patients population who received MRI over this time, then we see that about these 60 patients, according to the age and on the time of the operation, the cardiac function and the cardiac index decreased over the time, and all these adults are anywhere in between of 2 and 3 liter of the flow volume. It is absolutely not normal. Can we do anything against? Can we improve it anywhere? In this well-known publications, 2010, if we summarized risk factors, such as the old modification of the Fontan operation, using of diuretics, or symptoms of the heart failure, then we have high rate of the hospitalization and the risk of the death. it is one way that we can use, just summarize these risk factors. And if we have 3 of them, nothing can be good. I do not think that we can wait and summarize. We should start to treat it. But that we should know which kind of the ventricle we will treat, the absent one or the systemic one. We can treat the stenosis, we can reduce the pulmonary resistance, probably. We can prevent the thromboly, we can improve the venous flow, and we can do not more for the systemic ventricle. Probably treatment of arrhythmias, controlling of the blood pressure, reveal of the hypoxemia. This is a picture that I stole from Professor Gewillig. It is well known. Just once more to speak about the Fontan circulation. The flow arise from the ventricular function to the aortic pressure, and then it fall down to the central venous pressure, to the pulmonary arterial pressure, and after that we have only the small step to the left arterial pressure, and the circle is closed. It is only a small step, but to pass through the step is extremely difficult. If you think then it is go in this way, it is not so. It is possible only in Canada. In the Fontan circulation, this absolutely free flow functioning in another way, probably in this one. We need extremely high power to produce our preload for the single ventricle that is very fragile. And we have only one ventricle. The first point is we need the normal breathing. It was also the concept of William Harvey. But very often we do not have it. We have reduced vital capacity. It is about 67% of predicted. We have diaphragmatic palsy in this one patient, bilateral. The respiratory muscle weakness and the restrictive thoracic cage. And in this comparison of the Fredrickson in 2001 was shown that in all age groups of Fontan patients, in compare with healthy population, the forced vital capacity is significantly decreased. Therefore, we need this, but we do not have it. How we can treat it, I don't know exactly, but in the last years we have many publications with very small amount of the patients with the training after Fontan, also with the training of the breathing that can probably improve the Fontan flow. We know also very good that we should treat the arrhythmias to prevent the thromboembolic complications, and it should be made very aggressively and so early as possible. We should avoid bradycardia to maintain the cardiac index, and we should avoid the tachycardia to prevent the ventricular function and prevent the thrombosis, because in this data summarized from different publications, we have approximately more than 1,000 patients that were evaluated in regard of the thrombus formation, intracardiac thromboembolic events, and the silent pulmonary embolism that probably can negative work in regard of the increase of the pulmonary resistance over the time, and the incidence is up to 28%. Therefore, the question regarding the anticoagulation, I think it should not be discussed. It is necessary. What can we make actively? We can reoperate the patients if it's necessary, and mostly it is the conversions. In all studies, the conversions by extracardiac modifications if we have the typical complications of the arteriopulmonary connection, for example, and that can be in huge amount of patients. This is in this well-known publication of Mavrodis, more than 100 patients that were reoperated from the arteriopulmonary connection that is working in this way to the extracardiac connection with aggressive arrhythmia therapy, with very good long-term results and late survival more than 90%. And of course, in big centers nowadays, we perform extracardiac conduit or intracardiac tunnel or conduit, I would say. Therefore, this is a problem that we can, that we have any kind of solutions. once more for the improvement or for treatment of the absent ventricle, not of the systemic ventricle, this operation. We can also use our interventional techniques. We can close this huge venous collateral or this kind of hepatic arterial collaterals. We can put the stent in the conduit thrombosis to improve the flow, or we can use a couple of kilograms of coils and Platzer to close different collaterals. This is necessary to improve the saturation, to improve and to prevent the ventricular function on the long term, and this is working, but these are active follow-up. What should we do with this kind of patients? We shouldn't go through this table completely. These are 9 patients of our group with failing Fontan. The incidence is not so high, but the treatment is extremely complicated. Two of them died, one of them received heart transplantation, and 6 are probably under remission. That we should know exactly in these patients what is the primary problem, the ventricle function or the pulmonary resistance. Then we can probably think about the correct therapy. For this one, I think it is too late to think about any kind of therapy but the heart transplantation. And we will get these patients. And the medication is not really possible. But if we check these results of the last years, then the initial problems with the heart transplantation after the Fontan operation with survival about 32% increased to 70 and more %, and it is approximately comparable with the other patients population. And we have, if we summarize all this data together, about 400 patients. This is one way, but this is the way for the terminal deterioration of the ventricular function. As we know, this problem comes much more earlier, and we should recognize them earlier. The Preload enteropathy, from my point of view, it is a rare complication, but if we have it, we have no chance to treat it correctly. Budesonide therapy was introduced with very good result. Conclusions: oral budesonide is an effective therapy for treating Preload enteropathy after the Fontan operation. But this is a study with 9 children. And in this study, the main point was not on the heart and not on the lung, but probably on the gastrointestinal tract to improve this situation. If we take a look on these pictures, these are the publication of Ishida et al. From 2012, and we can recognize that in the upper picture, A, B, and C are the standard pulmonary arteries of the failed Fontan patients, and the D is the normal. Therefore, this overexpression of the endothelin-1 and endothelin receptors in the pulmonary arteries of failed Fontan patients, the same one, this is immunostain of the endothelin-1 in the failed Fontan patients, upper and the normal. Therefore, we can say, great, we give them Bosentan, and all will be good, and it was done in these 2 studies. 10 patients received Bosentan for 3 months, and no change could be noted after the 6-minute walk testing. Therefore, no improvement after treatment with Bosentan in this failing Fontan circulation. The other 32 patients, this is a huge amount for our population, received exercise capacity testing and unchanged peak oxygen uptake, proBNP, or heart insufficiency. No efficacy of the Bosentan. Probably we had more luck with Sildenafil. This was good design study, crossover, placebo-controlled, and so on. And the results were encouraging because after the taking of placebo, after the taking of Sildenafil on the end of the study, we have decrease in the respiratory rate and decrease in the ventilation on the exercise. Therefore, the patients need low energy to maintain the circulation. And in this one study, it was increased ventricular systolic elastance and improved ventriculo-arterial coupling after the therapy with sildenafil also. It was measured on a tissue Doppler, and we can see in these two lines that it was significantly improved with R square of 0.7, probably because of the better preloading of the ventricle, the function and the interfunction between atrium and ventricle was much more better. And in this well-known study of Giardini, the patients who received sildenafil improved their cardiopulmonary capacity significantly, and only these patients with impaired endothelial function, also therefore Fontan patients, know the normal. Therefore, many points speak for using of this therapy in Fontan patients, and if I summarized all articles that were published in the last year with sildenafil therapy, then we have 180 patients. It is not so low for our patients population, and all with positive effect. Different designed from double-blind placebo control to retrospective. Of course, between 6 and 45 patients is also a huge difference, and 2 of the studies were early postoperative, where the giving of sildenafil is sometimes not really controlled. I'll receive this, but I think this is a possibility for treatment. What is with other kind of medication? There are 78 adult patients from our patient population, and different medications that they get in our outpatient department through the long-term follow-up. Anticoagulation, 35%, only 35%. Angiotensin inhibitor, beta blocker, diuretics, digitalis, antiarrhythmica, sildenafil. No correlation with the time, no correlation with the indication. Adult patient received more beta blocker and diuretics. Not try to read it, it is just to look. The guidelines of European Society for Cardiology for treatment of the acute and chronic heart failure, 2012. We just take this algorithm, suspected heart failure, or we just take this algorithm, diuretics, angiotensin enzyme inhibitor. We'll read it through, we go through, and we know all this we need. Which medication and which time, and so it is so simple that probably the patients can do it alone without us. But nothing for this algorithm can be used in our patients' population. And that is not the end. The indication, pharmacological treatment for heart association functional class 2 to 4, systolic heart failure. All is clear. The class is recommended, the level. The data derived from the multiple randomized clinical trials or meta-analysis. And we know what we should to do. And if we collect all these studies that were presented in this to provide these guidelines, that we have for different kinds of medications, the total amount about 45,000 patients that were investigated in the huge population to provide these guidelines. What do we have for our patients' population? This is a really big study, 230 infants with single ventricle during the first year of age. And that is the biggest one and the last one. But it's very well designed. 185 patients complete the study. They received Enalapril, and on the end of the study, we have no differences to placebo. The main point was weight to age score, therefore the clinical signs of the heart failure, the gain of the patients, no differences. It was also no any differences in all hemodynamical parameters that we should not read in this table. All they were not significant in the patients who received Enalapril and who not. And the conclusion was that the administration of Enalapril to infants with single ventricular physiology in the first year of life did not improve somatic growth, ventricular function, or heart failure severity. The similar study we have also for patients after gland operations with a low amount of patients, but also without results that allow us to improve the cardiac index. This is the explanation for this probably. The level of the norepinephrine is much more high as the normal patients, and it remains higher, and the patients, it is cardiopulmonary capacity, reach the maximal cardiopulmonary capacity much more early as the healthy adults. Missing preload, missing peripulmonary pump. In patients with Fontan circulation, the activity of renin in the plasma is significantly involved in the maintaining of the resting levels of arterial blood pressure. And hemodynamic abnormalities, in addition to impaired cardiac autonomic nervous activity, results in an inability to quickly to adjust the rapid change in the physiological conditions. Therefore, they get no preload, they cannot go with during this exercise, they cannot improve their conditions. The heart rate, what we can also do for the single ventricle, is the same situation. They start on the exercise testing a little bit high, it is about 10% in the normal population. We reach the maximal heart frequency earlier, and the exercise capacity is lower in the normal. And in our study, we can also show that the cardiopulmonary capacities depend on the maximal heart rate. But we spoke at the beginning, the heart rhythm in these patients is mostly a huge problem. Diminished parasympathetic nervous activity associated with elevated heart rate at rest, 10%, and the peak rate achieved during exercise is significantly lower than for healthy pills, suggesting chronotropic incompetence. But the heart rate is the single possibility for the Fontan patients to improve their conditions and to improve their cardiac output. Therefore, together with the limited breathing and limited heart rate level, we have not many points where can we improve this hemodynamic. The beta blocker in patients after Fontan operation, 50 patients, 18 Fontans with ejection fraction lower than 50%. The question is how is it measured, of course, in this difficult anatomy. The doses of Carvedilol was increased over through the 11 months, and the endpoint were improved of the cardiothoracic ratio. It was significant. The reduction of the doses of furosemide, it was significant, and the improvement of the ejection fraction in mean. How is it measured? If we need only to improve the cardiothoracic ratio in these patients, we can use also this way. This is a patient after the gland operation with clearly impaired ventricular function. This is the X-ray of this patient. This is the same patient of the assist device. Dr. Potapov explained all things regarding the assist device in different patients. The cardiothoracic ratio is better, and after the transplantation, it is a normal cardiothoracic ratio. And this is a study with more than 500 patients with different medication summarized from the 7 big centers in the USA. And there was no significant association in the giving of the in the therapy of the heart failure with ventricular systolic dysfunction, with any finding of the echocardiography with the right ventricular morphology probably. It was no correlation with the ventricular systolic dysfunction in the administration of the diuretics or the glycosid. And the amount of the patients who take a beta blocker, calcium channel blocker, or antiarrhythmic agents was so small that could not be analyzed. Therefore, medication use rates varied widely among the centers, even with controls for center differences in patients' characteristics. A prospective therapeutic trials are needed to guide the medical treatment of the Fontan patients. We start yesterday with Da Vinci. This is also Da Vinci. Keep clear of the physicians, for their drugs are a kind of alchemy. You know that medicines, when well used, restore health to the sick. know this well, and you will know the opposites. What we can do, we can test the cardiopulmonary capacity at least to set a point for the beginning of the therapy. We know that the cardiopulmonary capacity of the Fontan patients is reduced at about 50% in median in compared with normal population, but this is not the point. The point is the risk predictive values and risk values. For example, in the study of Fredrickson, the cardiopulmonary capacity low, the 60 milliliter per kilogram per minute, or the maximal heart rate low, the 120, was a risk factor for mortality. And this is a view that we should use in the cardiopulmonary testing. Failure of the medical care, preoperative selection is mandatory for optimal long-term outcome. If you make this mistake before Fontan operation, it's too late to try to improve it using any kinds of medication. Symptoms develop at an advanced stage of decline Fontan circulation. We must find it much more earlier, before we have clinical symptoms. In addition to the abnormal cardiac state, recent studies have demonstrated impaired cardiac autonomic nervous activity, elevated neurohormonal factors, and impaired endothelial function. The inability to definitively treat a truly failed Fontan with measures other than cardiac transplantation. But we will try. And probably exercise testing is a good way. This boy after Fontan operation is 5 years old, have no problems, and he can show us how to do it. The missions and the visions, this is a mission. More than 6,000 patients that were published all over the world. This is not a long term, these are all publications in all parts of our world with low early mortality. Our goal is to improve the long-term mortality. I found 3,260 articles in PubMed Central regarding the Fontan circulation. The vision is get together, and this is the last one, the human heart awaits rebuilding. This is a study where the decellularized rat hearts were preloaded and stimulated, and by the day 4, they observed the macroscopic contractions. By the day 8, under physiological load and electrical stimulation, contracts could generate pump function equivalent about 2% of adults or 25% of 6-week fetal heart function. And this is a completely decellularized human heart. Thank you for your attention.